express my gratitude to the organizing committee of the WINCAS and WCC to asking me to present this Padmavati Oration. And I'm particularly grateful to Dr. Josna Madhuri and Dr. Shiva Chabra, who requested me to present this topic, particularly coronary microvascular dysfunction, the next emerging frontier in ischemic heart disease. So there is, why admit screen is coming to me.
Sir, your screen has been shared, sir. You can go to the next slide, sir. Okay. You can run the slides without any issue.
No problem. So we all are aware about the pathophysiology of ischemic heart disease, and various incriminating factors are atherosclerosis, vasospasm, inflammation, and coronary microvascular dysfunction. So it always existed. I remember during my internal medicine training, we always used to talk about diabetic microangiopathy, which is, if we talk of coronary circulation has epicardial artery, which is 5 millimeter to 200 micron. And then there are microcirculation, which are 200 micron to 50 micron. Initially, we were aware about coronary microcirculation as a diabetic microangiopathy. Then slowly we came to know in 2017, INOCA and MINOCA, then in SARS, and then during ischemia in a STEMI, during ischemia perfusion, 50% of the patients with STEMI have associated microvascular dysfunction. And those are the patients who do not do well with the STEMI. The prognosis is poor because the myocardial perfusion that we have done with the PAMI is not benefiting them because there is a microvascular dysfunction, 50% patient. So those are the patients who will have poor prognosis, will present with aneurysm, heart failure, and morbidity and mortality, higher morbidity and mortality. So understanding this particular problem, the special therapy has been developed, particularly in anterior myocardial infarction, leading to LAD occlusion, due to LAD occlusion. And this supersaturated oxygen therapy is given through the catheter, which is engaged in the left coronary artery. And it is given for 1 hour. Total dose of the oxygen is 1000 millimeter Hg. The benefit that it has received is it reduces the endothelial swelling, which occurs in the microcirculation in STEMI, and it also reduces the sledging, which is seen in the microcirculation during STEMI, particularly anterior-wall STEM, anterior-wall myocardial infarction. So this reduces that remarkably, and this is to be done only after you open the epicardial artery with the PAMI. And that reduces endothelial swelling, increases coronary blood flow, reduces myocardial injury, reduces infarct size, reduces free radical, and one year mortality, and even failure rate and hospitalization rate. So remarkable benefit. As soon as it was introduced with the first study, this was approved by US FDA for this use. So microcirculation is playing a big role. All the time it has been playing a big role. But the problem is we were unable to see the microcirculation. And to tell you, epicardial circulation is only 10% volume of coronary flow, whereas microcirculation contains 90% volume of the coronary flow or myocardial flow. But 10% epicardial artery gets 99% attention, and the microvascular circulation gets only 1% attention. The reason being, it is not visible to imaging. It is so small, it is not visible to imaging. So we have to find out some ways by which indirectly we can interpret what is happening in the microcirculation in a given patient of coronary artery disease or ischemic heart disease. The reason being the prognostic implication. It increases mortality 4-fold and MACE rate 5-fold. So this is a significant contributor to morbidity and mortality. All the time we are looking at epicardial artery, but it only takes care of total 10% volume in coronary circulation, whereas 90% coronary circulation comes through this microcirculation and which is not visible to human eye. But it can be studied on angiography if we carefully see if we have a TIMI3 flow, that means entry into microcirculation is normal. If TIMI flow is reduced, that means entry into microcirculation is affected and there is a slowing in the TIMI flow. Same way, exit of the coronary circulation from the microcirculation is interpreted by myocardial blush grade. If it is grade 3, then the exit is through the microcirculation is normal. So entry and exit both are very important in microcirculation. Otherwise, if exit is blocked, then also myocardial injury will continue to go. Another panel, lower panel, we see myocardial blush grade at 0. No dark shadows are seen there in RCA territory. So this is very important point that I want to make. We need to every time carefully look at myocardial blush grade, which is very important. Now there are several studies which have expressed that there are so many patients who have angina unstable and ACS, but they have normal coronaries, and 65% of them are women and 32% are men. So this disease of microcirculation looks like it's predominantly happening in the women, particularly the menopausal women, because of the hypoestrogenic effect, the hormonal change that happens with the menopause. The interesting study that is being presented in Circulation showing that if you look at the mortality trend due to CAD from 1980 to 2020, up to 2010, the mortality trend were reducing with the advancement in pharmacological, catheter intervention and surgical intervention. But after that, slowly mortality is rising and it achieving again the alarming stage. So there are several studies done. What other factor other than atherosclerotic disease is responsible for them, and their microcirculation has been incriminated, and female more than the men. Now there is epidemiological shift occurring. The diabetes, obesity, hypertension, hyperlipidemia is more. Smoking has reduced. Rupture plaque that we used to see STEMI due to rupture plaque has come down. But hospitalization due to second MI and heart failure with a preserved ejection fraction has gone up. So essentially, what are we looking at? We are looking at the patient who presented with chest pain. Non-invasive testing showed ischemia, but coronaries are normal. So those are the patients we need to study microcirculation in greater detail. And microcirculation dysfunction has been classified into 5 classes. And what we are today looking at is the primary type 1, where you have a normal coronary, but there is a angina going on and there is ischemia evidence by non-invasive testing. But there are other factors, even including cardiac transplant patient can have a microcirculation dysfunction. So functional CAD is the term that may be suitable to use. And then there are several terms which are described. One in stable angina as a INOCA, in acute coronary syndrome as a MINOCA, and ANOCA means the patient with angina. But there is no other explanation. Now, apart from that, coronary microcirculation, we were always knowing about syndrome X in women. But lately it has been described syndrome Y due to slow flow syndrome, no reflow syndrome, and Takotsubo cardiomyopathy, which is stress-induced cardiomyopathy. Epicardial vasospasm, that is focal vasospasm, is due to Prince metal angina. But microvascular vasospasm is generalized, and it can produce similar angina and ischemia, and morbidity mortality is equal. And almost 50% of patients of CAD have a microvascular disease. Now, coming to another study which has shown that microvascular dysfunction is predominantly seen in 50% patient of CAD. Out of that, 67% are women. Amongst the patients who have undergone angiography and CFR, if their CFR is low, obstructive disease is seen more in the men and less in the women. So this is another observation which has further enhanced the possibility of microvascular dysfunction being evoked in women, particularly after the menopause due to hormonal disturbance. Now, ischemia trial, which is a very huge trial, 20% patient had moderate to severe ischemia on core lab verified testing, which is very reliable. But anatomically, there is no obstructive disease in the coronary artery. So what are we looking at? A mechanism of myocardial ischemia. We know atherosclerosis, we know vasospastic angina, but this new microvascular dysfunction, which is encompassing the CAD and cardiomyopathy, related cardiomyopathy, Takotsubo, which is also explained. So why should we care? Because it presents with adverse outcomes as MI, heart failure, arrhythmia, stroke, and death, and mortality is also very high. So significant healthcare problem it creates. A lot of women visit and men visit in the emergency with chest pain. ECG shows ischemia, and they have a debilitating symptom, so their life is affected. They're unable to cope up with the life. And this limits their exercise, this limits their quality of life, and 50% of the patient of STEMI have a microvascular dysfunction for which that supersaturated oxygen has been tried, and it is said to be very effective in treatment of microvascular dysfunction, particularly in anterior MI, after the PAMI, soon in the cath lab itself. So when do we suspect it? The microvascular dysfunction could be there. A patient who's got exertional chest pain, abnormal non-invasive testing give evidence for ischemia, but normal coronary angiogram. That we have been talking, slow flow, Takotsubo. So all these patients do have, we can suspect. Is there any way we can evaluate them, since they are not visible by any imaging technique? They are so small. So we can evaluate them non-invasively by PET scan, echo, and CMR, cardiac MR, and non-invasively CFR and IMR. I will cover the CFR, IMR in greater detail further in my talk. What we are doing at the moment is doing a fractional flow reserve if we have a block in the moderate block in the epicardial artery. But epicardial artery has only 10% of the resistance. 90% of the resistance is in the microcirculation, that is in arteriole and capillaries. So we need to study that. So we need to do a CFR. What is CFR? CFR is nothing but a hyperemic flow divided by resting flow. And it can be studied non-invasively, invasively. Invasively, there are two methods, thermodilution and intracoronary Doppler wire. And both these readings are abnormal in thermodilution CFR if it is 2 or less than 2, equal to 2 or less than 2, and intracoronary Doppler equal to 2.5 and 2. So how to interpret CFR? CFR is a common denominator for epicardial and the microvascular. So it integrates both the circulation. So if you have a block, the CFR will be reduced. Epicardial artery is blocked, CFR reduced. But if you do a stent, CFR will improve if there is no microcirculation. If microcirculation is there, microcirculatory coronary microcirculation, so circulatory dysfunction is there, then CFR will be still high, and their prognosis is very important factor. Prognosis will be affected. We always learn about 70% as a significant block in epicardial coronary artery, and that is defined by coronary flow reserve. As you see, the resting maximum flow is there, but as the block increases between 40 to 80%, it starts reducing and it becomes zero when it is 100% block. So if using a Doppler wire, which is a volcano machine wire, if we do a Doppler study, CFR may be abnormal in a epicardial artery block. If you put a stent, CFR will improve and become 3. But if you have epicardial and microvascular disease together, CFR will still improve, but it will improve minimum, and it will still continue to show low CFR, and their prognosis is not good. Morbidity, mortality is high. I'll come to this, how we do the hyperemic testing or provocation testing with adenosine acetylcholine, and I'll cover that in greater detail. What is the latest innovation is CoroFlow. CoroFlow wire invented by Coroventis, but this is now taken over by Abbott. So Abbott has this wire. It is available in Europe and America, and it's 6 months to 1 year time. It will come to India also. The idea of CoroFlow wire, it has, apart from having a pressure sensor at the tip, it also has thermistor, means thermal sensor. One proximal and another one in distal. And these values which are evaluated by CoroFlow are validated already. So FFR value more than 0.8 is normal. CFR more than 2 is normal, and IMR less than 25 is abnormal. More than 25 is normal. More less than 25 is normal. So these are all values are validated completely. So what are we trying to assess? The index of microvascular resistance. It is also called as IMR. This IMR is nothing but the low diastolic pressure into mean transit time at the hyperemia. What do we mean by transit time? That I'm going to explain. So we have this wire which has CoroFlow wire, which has, apart from a pressure sensor, it has thermistors, thermal sensors. So in the proximal portion at the guiding, where the guiding is engaged, and distal. So we inject a normal saline at the room temperature, and automatically the machine will calculate the transit time of the saline from proximal thermistor to distal thermistor, and that will note the change in the temperature. And that transit time should be evaluated for 3 times. So therefore it is called as mean transit time. And we have one case elucidated here. It's from the literature. And this case says that patient had a PCI done, but he continued to have angina and dyspnea on exertion, and angiography was done. The stent was widely patent. So they decided to do the physiologic testing, which reported their CFR is low, less 1.2, and IMR is high, 41. That means there is microvascular dysfunction in this patient. So treatment has to be started for microvascular dysfunction. Even that is also being evolved currently, because there is no specific targeted therapy available at the moment, but slowly it is being evolved. And we can also do a Doppler wire and the CoroFlow wires simultaneously, side by side in the LED, and we can get a recording simultaneously. That helps in assessing and coordinating the parameters that we are getting. That gives us confidence that what we are getting, the parameter, if it is low, then it is definitely low because it is evaluated by 2 methods. Now if we have IMR more than 25, CFR less than 2, then we have a microvascular dysfunction. If there is no epicardial disease, coronaries are normal in ANOVA. Similarly, if and then that patient has microvascular angina, we can say that. But when we do invasive procedure, diagnostic procedure, apart from the first one, we do acetylcholine test for vasospastic angina. Acetylcholine is injected through the microcatheter placed in the LED directly. And if you see a 90% reduction in lumen diameter spasm due to spasm, then that indicates vasospastic angina. So vasospastic angina diagnosis can be made. Whereas if there is no spasm with acetylcholine, then it's non-cardiac symptom. Non-invasively, we discussed PET. PET is very expensive investigation. It's cost about 25-30,000, and it's not available everywhere because the cost of the machine is 30 crore rupees. So only few centers in India have it, and it's very good to have it. We can non-invasively evaluate the CFR. That will tell us about the microcirculation, and we can do the angio and see the epicardial artery. So non-invasively, we can combine at this stage. If we have a patient who's got angina and we want to see the microcirculation status, we can do PET. Interestingly, for echo-savvy people, you can put a cursor, pulse wave Doppler cursor, through the apex. And during systole, you will see this flame coming. It will disappear during diastole, but systole, you will see this flame coming. That is indicative of flow in the LED. And velocity of this flow can give us CFR. That's very simple. That's calculated through the machine software. What is so important about knowing which level the problem exists in ischemic heart disease, whether it is microvascular level or it is at the epicardial level? If we have a adenosine test done and CFR is low, their prognosis, their MACE rate and death is very high. So it's very important. This is long study done and reported in American Journal of Cardiology in 2019, 9.7-year follow-up, and they have all shown that adverse event in women are particularly high if the CFR is low. This is an algorithm diagram which I need to explain you. If you have a patient with chest pain, and non-invasive testing shows there is evidence for ischemia, but coronary is normal, we can do a PET and see the CFR. With non-invasive testing, CFR of less than 2.5 is reliable. With the invasive testing, it is 2 CFR, less than 2 is indicative of the coronary reduction in coronary flow. So if you have CFR low with normal coronary and IMR high, then it is microvascular angina. But if it is more than 2.5, we do an acetylcholine test. If acetylcholine shows no more than 90% diameter narrowing, no angina, no ischemia, that means patient doesn't have vasospastic angina, but we need to do adenosine provocation test to test whether CMR is low or not. If CMR and IFR, if CMR more than CFR more than 2.5 and IMR more than 25, that means when it is normal, then it is false positive ischemia. And if it is abnormal, then it indicates microvascular angina. Then some patients, when we give adenosine challenge, they develop a chest pain, but they don't have ECG changes. Those are called as obnoxious stimuli from adenosine, and they are called as nociception. And that is how. And about the stenosis, we know more than 70% we do angioplasty. If it is moderate, we do FFR, and then accordingly decide. So basically this, and now guidelines suggest that the invasive and non-invasive functional testing now should be part of the ischemic heart disease program. So what we see as obstructive CAD as a phenotype of one of the phenotype of the IST is only tip of the iceberg. The main 90% circulation is in microcirculation. So that is where the main problem is, and that needs to be studied, and we have to develop targeted therapy in relation to that. And that is what I mean to say, that it is the atherosclerotic epicardial block is only tip of the iceberg, but microcirculation can produce so many diseases like inoca, minoca, cardiomyopathies, heart failure with preserved ejection fraction, obstructive CAD, and there are several other conditions it can produce. There's only one trial which has been done in UK by Colin Berry, assessing the physiologic assessment by invasive method, by Coroflow, and trying various drugs in various settings to decide which drug will be effective in patients with microvascular angina. And they divided the patients into two groups: vasospastic angina, this is RCT, mind you, vasospastic angina and microvascular angina. So what is vasospastic angina? When narrowing of the epicardial artery more than 90%, then it is vasospastic angina. But if it is less than 70% and less than 70%, but ECG shows changes, there is angina is reproduced, then perhaps it is microvascular angina, even by acetylcholine vasospastic angina testing. Microvascular angina, we always say by Cohadis diagnostic criteria, the symptoms of myocardial ischemia, unobstructed coronary artery, and proven to be microvascular dysfunction, high IMR, low CFR, and acetylcholine suggests spasm in microvascular territory. So if the FFR is normal, no obstructive disease, and normal CFR, normal IMR, no negative for acetylcholine testing, then that is declared as chest pain non-cardiac. This is the study which they have done for testing the drugs, as I said. And what they have done is they have blinded which drug is given in two groups. One group knew the drugs which are used, other group did not know which drugs are used in a given patient. So they first they did the angiography. Angiogram shows no coronary obstruction, no obstructive coronary artery disease. Then they did the adenosine, IMR, and CFR test. If CFR is normal, then patient is subjected to acetylcholine vasoreactivity test. And if it is disappearing like this, like it is shown, then it reappears after nitroglycerin injection. Then it is most probably a vasospastic angina due to epicardial artery. And treatment advice was cessation of smoking, calcium channel blocker, long-acting nitrate, and lifestyle changes. And similarly, if we have a patient whose IMR and CFR are abnormal, but FFR normal, we'll still do the acetylcholine test. If it is negative, then perhaps microvascular angina. And this is microvascular angina is non-endothelial. That is the type of endotype. When it is positive due to acetylcholine, that means less than 70% spasm in the coronary artery after we inject acetylcholine, but there are ECG changes and angina is reproduced. That means it's a microvascular spasm causing angina, and those patients are benefited again by calcium channel blocker and those like that. If it is normal, then we advise them stop anti-anginal discharge and consider non-cardiac investigation. So treatment strategy, just in brief, I will say that microvascular dysfunction, low CFR, high IMR, and with the adenosine testing, that's non-endothelial. That is one type of endotype. And second one is endothelial endotype, which is where the acetylcholine causes epicardial vasospasm with normal IMR and CFR. So drugs used are calcium channel blocker, longer acting nitrates. And similarly, endothelial dysfunction, if the acetylcholine causes less than 70% epicardial spasm, and normal and affected IMR, abnormal IMR and CFR, suggest we give beta blocker, particularly nobivolol, S inhibitor, statin, and lifestyle modification. And if there is adenosine nociception, then treatment is imipramine, a drug of choice. Various other proposed directed therapy are there, which are helpful in reducing endothelial function and also in modulating vascular tone. So various drugs are used and tried. So many drugs are there which are proposed as a potential treatment for microvascular angina. So in conclusion, in Cormaca trial, coronary angiography failed to demonstrate vasospastic and microvascular angina. Stratified therapy is effective after doing the functional testing with Coroflow. And those patients group which were blinded, some part of the group knew what treatment to give, microvascular dysfunction is there. Another group did not know the treatment. But the MACE rate was similar at 6 months, 2.6%. Vasoreactivity, if it is there, is proven by acetylcholine test. And in that also CMR and IMR and CFR can be abnormal. Most studies are of course needed to further document and make a proper decision on this problem. So concluding my talk, presentation of functional CED vary from stable angina to MI, imaging, non-invasive imaging, and invasive functional testing, very useful in diagnosis of ischemia. Microvascular dysfunction has two endotypes, endothelial and non-endothelial type, and Doppler and thermodilation methods are very good in assessment of the microvascular disease, microvascular dysfunction present or not present. And coronary provocation testing increases the certainty of diagnosis in this patient. More RCTs are needed to test the certain specific therapies in CMD. Now, what in brief, I would say this is a new epidemic. It is described as a new epidemic. CMD is described as a new epidemic, which has a very high MACE rate, death rate, heart failure rate, and hospitalization rate, very high cost. So, but there is a knowledge gap. Many of us don't understand what is microvascular dysfunction. Moment we do, suppose if patient come with angina to us, we do an angiographic evaluation. If angiography is normal, we tell him non-cardiac chest. But now we should not stop there. And I'm glad that Vinkas thought of introducing our crowd, cardiologist crowd, this CMD, how to evaluate completely, and how to think of CMD. When do we think of CMD? It's a very important aspect. We need larger trial to come and close this gap so that we can, all of us should talk about in all the forums, scientific forums that we have, various conferences that we have about this microvascular dysfunction, and educate people how to evaluate it and when to suspect it. That will help in reduction of MACE rate and death due to ischemic heart disease. Thank you very much for asking me to talk.
And thank you very much, sir, for a nice illustration of with the diagrams and everything, the importance of the microvascular, the dysfunction. Yes, the FFR wire has not only the pressure sensitivity, it has a temperature sensitivity, so that we can use an FFR wire to calculate the CFR also. So Dr. Wonder, sir, please, would you like to add? Because it is a oration, we can't ask any questions. So no. I wanted the comments from the Dr. Wonder, sir.
I permit you to ask questions if you have it. I think he's not there, or he's there. Dr. Wanda, can you hear us?
Yeah, probably he's not there.
Yes.
Sir. Yes, sir. Thank you very much, sir, for the nice demonstration of the with the cases you described it very clearly. So, thank you.
Thank you very much. And sorry for inconvenience due to that technical snag. We almost lost 10 minutes, 15 minutes time in that.
Yeah, that's true, sir. But it's okay, sir. Thank you very much, sir. Can we conclude this session, sir?
Oh, sure.
Yeah, thank you.